Moving on to our last session before the tea break, inviting Dr. Srinivas Kishore Sistla on stage as a speaker of the session, going beyond the standard, implementing targeted approach for the management of OSA. I also request Dr. Nikhil Sridharan, Assistant Professor, Department of ENT, Government Medical College, Kozhikode, to kindly chair the session.
Dr. Srinivas Kishore Sistla is a highly experienced ENT and sleep surgeon practicing at AIG Hospitals in Hyderabad. With 23 years in the field, he holds an MBBS and MS in ENT from Manipal Academy of Higher Education in India. He has completed fellowships in endoscopic sinus surgery and sleep apnea surgery at renowned institutions like the University of Pennsylvania and the University of Wisconsin. He has authored numerous papers on obstructive sleep apnea and is a respected faculty member in various international and international workshops. His clinical attachments include working with notable professors in the United States and Australia, further establishing his expertise in the field. Over to you, sir.
Thank you very much for your kind invitation. At the outset, let me congratulate Sanu and Davis for the second. Let me congratulate Sanu and Davis for the second edition of SnoozeCon. Welcome everybody. My talk is going to be a little different. So it's totally going to be on in regular day-to-day practice. Why do you make the decisions that you make when a patient is sitting in front of you and decide on what kind of treatment for that particular patient? That is what I want to talk to you in the next 20 minutes or so. So without further ado, let me just proceed. We all know obstructive sleep apnea has varied predisposition factors, right from genetics to skeletal frameworks to muscle collapsibility, so on and so forth. There are various pathophysiological mechanisms that are involved in how these predisposing factors interplay. There are varied clinical presentations. For example, men present very differently from how women present with the same condition. And of course, the consequences of those clinical presentations are also very different. So when you're talking about obstructive sleep apnea, you're talking about the potpourri of these mix of things. Now, when it comes to prevalence in India, what was 7% in 2007 has now become 32.5%, which is sort of similar to what's happening all over the world. But for us, it's also important because when you talk about body shapes, we are a genetic pool. We are not the same. The person next to you is very different from how you are. We don't look like probably how a Southeast Asian looks or maybe a Caucasian looks. We are very different because genetically we all come from different sort of gene pools. So each one of us are very different. So you cannot have a standard protocol for managing all of this. So what is the current paradigm? How are we dealing with things so far? We perform a sleep study to the patient who comes to us. We look at the AHI, the first metric of measure, because we know that it's the metric. Then we offer CPAP. The patient says, I'm not able to use it or will not use it, or you are not able to convince the patient to use it. Then you say, okay, non-compliant. Then the next option is, okay, I will try mandibular advancement device or I'll do surgery. This kind of trial and error method is what we have all been doing, right? So if you look at all these patients, what do they all have in common? Sleep apnea. Every single one of them. But all of them look very different, right? All of them will look very different. And in order for you to understand a little further, I want you to draw your attention to these three patients. Look at this patient, look at this patient, look at this patient. They're all snoring. You can see that they're all demonstrating behavior which is something like apnea. Correct? Now, what would be the first thing to do for all of them? Sleep study. Correct? Yes? Now, this is the sleep study of the first patient, second patient, third patient. All right? I have circled, I'm not sure if you're able to see. Do you know their AHI? All three of them have an AHI of 50. But will you treat all of them the same way? Will this guy respond the same way as this guy and this guy to a single modality of treatment if you select? No, you won't. You're not going to get a particular result if you are going to hammer every patient with a single kind of modality of treatment. It's like, you're getting a book in equine medicine, broken leg, you shoot, infected eye, you shoot, splayed hoof, you shoot, runny nose, you shoot. You are going to give the same treatment for every ailment for every patient is not going to work. Hence, we need to understand what can we do to the patient sitting in front of us. And over a period of years, things have changed quite a bit. When we close our eyes and think of sleep apnea, what do you think of? You think of a man, you think of a short neck, you think of a belly, and you think of excessive daytime sleepiness. But is sleep apnea sexist? No, it's not. It affects every other person as well. It affects women, it affects adolescents, it affects children. But the mechanism is not the same. The disease is the same. The mechanism is not the same. So, we have now closely understood why different people are behaving the way they are, presenting the way they are, and having different comorbidities, having different outcomes to those comorbidities. And this sort of understanding helped us understand this basic concept. What is this concept? Which is the concept of endotypes. Now in CRS or whatever it is, we are now talking about endotypes. What is an endotype? Endotype is the underlying mechanism that runs that particular disease in that individual. Correct? For example, I might have an Innova, you might have an Innova, he might have an Innova, but mine is diesel, yours is petrol, his is hybrid. Similarly, you need to understand that all these patients are not driven by the single pathology. You have different pathologies. But one thing is common for everybody, and that is called as peak rate. Right? Peak rate is the ability of the individual to keep his upper airway open. So if you are a sleep apneic, your ability to keep your upper airway open is lost. That is common for everybody. But that pressure is not the same for everybody. You're with me, right? You understood this. Now, based on the severity of collapsibility of the upper airway, you may be a mild apneic or a moderate apneic or a severe apneic. For example, if you are a mild apneic, your ability to withstand that negative intrathoracic pressure is more than somebody who is a severe apneic who has 100 AHI. Their upper airway will collapse at +2. So supposing we pick some person in random, let's anybody for that matter, and we find out that their peak rate is -4 or -6, means what? They can withstand that negative pressure of -6 centimeters of water pressure. That means what? They have a very stable airway. That means what? Most probably they will not get sleep apnea. Correct? So if you probably take me, I may be between -2 and 0. And maybe we can catch somebody else on the road, he may be +2. Now, nature is not that kind, right? Because we figured it out, we know everything? No, we don't. Because there are 3 non-anatomical factors that come and mix with this anatomical factor, making management of sleep apnea a little difficult. So they are low arousal threshold, high loop gain, and muscle responsiveness. Arousal threshold means if I am able to keep my airway open and the amount of energy or whatever stimulus that I am requiring to keep myself open is waking me up in the middle of the night. So I may have a low arousal threshold. That means even with the slightest effort to keep myself open, when it is collapsing, I may wake up. That is called as low arousal threshold. Then there is somebody who, no matter how much my airway is collapsing, I won't wake up. That is high arousal threshold. The second person is somebody whose ability to keep their upper airway muscle open, because the dilatory muscles, which is the genioglossus and the tensor palatini, those dilatory muscle forces are not good. Hence, it collapses. The third kind of person is that their chemosensory receptors in the arch of the aorta and in the carotid body have become super sensitive to the concentration of oxygen and carbon dioxide in the body. Hence, the moment oxygen goes down a bit and the carbon dioxide goes up, you hyperventilate and throw out that carbon dioxide. If you throw out carbon dioxide, what happens? You can't breathe. Because what is the driving force to initiate a respiration? CO2. So if you throw out CO2, how will you inhale again? You will develop apnea. But what apnea? Central apnea. So people with OSA have this kind of combinations. But unfortunately, 60% of us will have combinations of this. Us means people who have sleep apnea. Now, there are people who have only upper airway collapsibility, and those are only 20%. There are people who don't have upper airway collapsibility and have only non-anatomical factors. They are another 20%. But 60% are a mix. So what does this Gyan give? What did this give you? We'll come to that. That we will first come back to the first thing, which is the PCRIT, which is the airway collapsibility. Now, even if we come to airway collapsibility, is your upper airway stable in every level? No. You have the nose, which is relatively stable. You have the larynx, which is relatively stable. And you have the pharynx, which is not very stable. So, when you talk about PCRIT, you are basically talking about the airway from the hard palate to your epiglottis. That is your part where you have to concentrate. So, now let's talk about the first thing, which is the PCRIT or airway stability. Okay, let's talk about that and see what we can do to fix that so that we can improve our outcomes. Now, let's start with the nose, because we thought that the airway starts from the nose, pharynx, larynx. Let's start with the nose. We all know that the nose is pivotal and primary in the management of obstructive sleep apnea, and I was talking also that nose has to be optimized even for CPAP to work. Why? We know that if the nose doesn't work well, there is dryness in the upper airway. If there is dryness in the upper airway, what happens to the surface tension? Surface tension goes up or low? Guys, come on, let's do this. Let's make it interesting. What will happen to the lips when they become very dry? They get stuck, right? So it requires energy to open up. Similarly, if your throat is dry and the surface tension goes down, so it gets stuck. So it becomes difficult for your airway to open up. That means you require more energy to open up, whether it is a pressure or whether it is anything, right? So more dryness, the surface tension becomes low, then it becomes dry, hence it becomes stuck. Point number 2, the most important gas that we talk about, nitric oxide. Now this you have to tell me. Where is the nitric oxide exclusively produced? In the sinuses, nowhere else. So if you take a patient and tracheostomize them and do nitric oxide assessment to the gases exchange that happens, you won't get nitric oxide. Why is nitric oxide important? Because it improves ventilation perfusion ratio. Because when we breathe, right, do we breathe only oxygen? We don't. We breathe a mix of oxygen and nitric oxide. It's very important. It also causes vasodilation. In fact, people say that it is the natural form of Viagra. That's a different thing. It causes vasodilation. So, it also increased ventilatory response to CO2. That means, remember I spoke to you about loop gain, where you are going to hyperventilate. If your nitric oxide goes down, that ability also goes down. Now, and we've seen that upper airway procedures can help you to get good outcomes for CPAP as well as multi-level surgery. But what is most important is when you deal with the nose and you want to increase the efficacy of CPAP or your multi-level surgery, you need to differentiate whether the problem is with the container or the problem is with the contents of the nose. Because, of course, Dr. Sukhvinder is going to talk about all this. This is a high-arched palate. That is a comparison of a regular palate. Because the roof of the mouth is the floor of the nose. So if we don't find out whether there is a problem with the container or the contents, even if you empty the entire nose, because the volume of the nose is very less, the problem will not get better. So if you do a septoplasty to a patient who has a narrow volume of the nose, will it improve and give outcomes? No. Why? Because the negative pressure in the pharynx is still happening. Because the volume is low, the lung still pulls against a small volume. Right? So our treatment will not be that successful. Now, if you look at it, classically, when we look at all your CT scans, do you see this? When you do your CT scans, if you have a gap between the tongue and the hard palate. So when you all close your mouth, where is your tongue? Can you feel the entire arch of the tongue to your hard palate and soft palate? Or you don't? How many of you do? The rest have to meet Sukhvinder. Okay, so, but you again have to differentiate whether the obstruction is lower down, that means the lower part of the nose, or in the middle part of the nose. If you heard Dr. Davis's talk about piriform plasty, you will have to differentiate again the nose into lower story and upper story. So what happens if there is no coupling? While you're doing intraoral DISE, this is what happens. Because the tongue cannot sit where it needs to sit, it keeps falling off into the upper airway. This, combined with low muscle tone, can cause problems. Hence, it is important that when you treat the nose, you differentiate with whether it's the problem of the container or the problem of the contents. That is also very important. So what do? So if there is an obstruction at the upper portion of the piriform, that is at the level of the frontal process of the maxilla, So we're using piezo, but you can use anything. In order to expand the diameter or increase the volume of the nose, you will have to increase the bone size. Doing septoplasty or turbinoplasty is not the answer. Increasing the volume of the nose is the answer in these cases. Now, the same thing can be done transorally. If you are addressing the lower part of the nose, that is the floor of the nose, if you do this kind of an axis, becomes very, very difficult. So for want of time, let me just fast forward the whole thing. This is something that we can do nicely. You can measure and then you widen the whole thing. So this is our owli appearance. What the skull-based surgeons have owli, we also have an owli. So what happens? If you look at the rhinomanometry in terms of metrics of measure, this is pre-op, this is post-op. So for those of you who know to read rhinomanometry, excellent. This is for you who do not know how to read rhinomanometry, this is pressure, this is flow. You should be getting more flow with less pressure, right? That means the more horizontal the graph, the more pressure you are putting for the said amount of airflow that's coming into your nose. So the idea is for you to be as vertical as possible. So this is expiration, inhalation on right side, left side. This is 4-phase rhinomanometry. So once you've measured it, you have objectively measured whether you have improved that airspace for that particular patient or no. This is the easy part. But how do you manage, how do you assess if there is a peak rate loss in the pharynx? Because I said -2, +2, all that, right? You understood that, right? But is it that easy? The idea is you want this to become this. This is a patient with high peak rate. That means airway collapsing. The patient's ability to keep their upper airway open is not there. This is high peak rate. That means guarantee OSA. This is low peak rate. That means airway is not collapsing. You're able to see the difference? Now, the idea is for us to get from that to that. So how do you do that? Easy, you can put a CPAP. CPAP will blow that open and act as a mechanical splint to keep the upper airway open, right? So that is one way of doing things. But we are surgeons. We want the upper airway open surgically. So in order to do that, we first need to understand what caused the collapse in the first place and what are the factors that are stimulating the collapse of the upper airway, right? Now, the first thing you need to look at is your airway collapsing or obstructing? There is a difference, correct? This is the tonsil, this is the tongue. If you are looking at the upper airway and if there are obstructions in the upper airway which is made the airway block, or if there is a block in the upper airway which is causing all the problems for the patient, then this is easy to manage. As opposed to an airway which is collapsing. Yes? Of course, don't look at the epiglottis. Look at the palate. Okay? Because we are talking only about the soft palate. So which is easier to treat? This or this? This is easier to treat. So the first thing you need to know to find out where the collapsibility or obstruction is coming from is rule out whether it's an obstruction causing your problem or collapse causing the problem. The second thing, once you found out that it's a collapse that is the problem, you need to look at whether the person is obese or no. Why? Because if there are parapharyngeal fat pads, the parapharyngeal fat pad will change your upper airway from a circle to an ellipse. Which is difficult to collapse? Circle is difficult to collapse. Ellipse is easy to collapse. So, if you have an obese patient and if you want their airway collapsibility to come down and you want to make the airway stable, what you should tell them? At least 30% of weight should come down. Not just giving a prescription of some weight loss medication. 30%, 25% weight loss is not a joke. With Wegovy and Manjaro, yes, but other than that. So that's very important. So the first thing you found out, whether it's a static obstruction or it's a collapse. 2, is there fat? And if there is fat, how do you want to change it? You want to lose weight. How much weight you should lose to get meaningful outcome? 25 to 30%. So that is the discussion you need to have with the patient. The third thing that can influence the shape of the airway other than the fat is the shape of the skull. Right? So here is a very beautiful paper from Raj Dedia's group from UPenn, wherein they found out that because of all the ultra-processed food and the food that we give our kids, the skull in the pre-industrial age has moved from this to this. So if you have a skull like that, what will be the shape of your airway? Narrow. Hence becomes easy to collapse. So they've also done measurements. So pre-industrial skull, look at the size of the nose, the shape, the gap between the molars, and look at the modern skull. Obviously, there is no space. So because of the food we eat, the kind of environment we live in, our faces are becoming more and more adenoid faces types. Right? So this also affects the shape of your upper airway. But these are all structures that affect the shape of the airway, correct? But how do you know how collapsing it is? How would you know that? Well, you can do this very fantastic, nice test for which you will have to go to Australia to get this done. Or you can look at the data of your sleep study very carefully. So if you have a patient's AHI, the first thing you need to differentiate is this sleep study an apnea-driven study or a hypopnea-driven study? If it's an apnea-driven study, look if there are static obstructions or no. Even if the apneas are 100 and you see lingual tonsils, bad septum, adenoids, tonsils, you don't have to worry. But if the patient's AHI is 100 and you don't see visible obstructions in the upper airway, that means it's a very, very collapsible upper airway and your surgery is not going to tinker that. It's not going to make an iota of difference. Bad surgical case. Similarly, if your sleep study is an hypopnea-driven study, that means what are hypopneas? Your upper airway is not completely collapsing, right? Because there is decrease in flow, but not complete cessation. Since there is a decrease in flow and no complete cessation, the airway is relatively better. That means the peak rate is somewhere between -2 and +2, not +6, +5, +4, no. That means some kind of a surgical intervention can be offered to this patient. So that is what the sleep study can tell you about the collapsibility, right? Or you can do a PAP titration. So here we are putting a CPAP and we are looking at how the airway is behaving at different pressures. We are doing it at 3 centimeters, 4 centimeters, 5 centimeters, 6 centimeters. Now, the higher the pressure that is required to open the airway, the higher the collapsibility. Yes? Is that clear? Right? So, if you do this and we don't find static obstructions and you have a CPAP opening pressure of the pharynx at say 15 centimeters of water pressure, means the airway is very collapsible or rigid? Collapsible. So, what is the ideal pressure? So, it is said that 8 to 12 centimeters of water pressure is a reasonably stable airway pressure wherein you can offer surgical treatment to your patient. Beyond 12, the airway is very collapsible and hence it becomes very difficult. So it has been shown again that what is the most convenient pressure for CPAP to be adhered to the patient? Again 8 to 10. What is that telling us again? That collapsible, if the airway is less collapsible, CPAP also will work better, surgery will also work better. If your CPAP pressures are about 18, 19 centimeters, like how Saad said, you need a BiPAP, right? Because you need more power to open that particular airway. Another very important thing that you need to understand is that the airway collapsibility differs by the location of the primary airway collapse. Means what? In your DISE, if you are seeing an obstruction at the level of the palate, at the oropharynx, at the tongue base, and also at the epiglottis, what matters is the location of the primary limiting site. Let's say soft palate. As Dr. Renuka was showing, that the moment she puts the nasopharyngeal airway, and if the airway opens, and the rest of the collapsibility below disappears, what is that telling you? That means because of that primary site, the rest of the airway is collapsing. So it's probably enough if you just treat that site, you don't have to treat the epiglottis, the tongue base, everything below that. Hence, understanding that is very, very important. And hence, putting the nasopharyngeal airway during your DISE is also very, very important. So how does one stabilize the airway? Barb sutures completely revolutionized the way we do palatal surgery nowadays. For want of time, let me just, Sanu, how am I doing? Should I get off? Huh? I will skip all this, and surgical aspects we can do later. Let me just talk the theory part, then we'll discuss surgery at any time. So all this surgery, what does it lead to? All these great surgeries of Barb and all, what does it lead to? It leads to stabilizing the airway. And it has been shown that a decrease of 9.2 centimeters of airway pressure, you are stabilizing the airway when you do surgery. It's not a joke. That is significant amount of resistance that you are offering to collapse. How do devices help? They also stabilize the airway. And this is how you measure the amount of advancement that you do in DISE. So millimeter by millimeter, while you do DISE with this device called the SandMass device, you can actually measure and see how the airway is opening up, and then you can titrate and create a mandibular advancement device. Understood. I got the message. So let me just skip everything and let me just talk a little bit about pharmacotherapy. I will take 1 minute. So it's just not about the drugs, or about surgery. There are so many medicines that you can actually use. You can use medication for anatomy, for upper airway muscles. You can use medication to reduce airway threshold, arousal threshold. You can also use medication for ventilatory stability, so on and so forth. And of course, last but not the least, no orthopedician will do a surgery without physiotherapy. No ENT or a maxillofacial surgeon should do treatment of OSA without myofunctional therapy. And there are lots of exercises. There are apps that are out there that will help you to do that. These are few books that have actually changed my thought process. This, of course, Patrick McEwen from the Buteco Institute. This is also from Patrick McEwen. Breath, of course, this is a New York bestseller. This is by James Nestor. These are one of the most excellent books that will change your idea about breathing and how it can change your life. So guys, no matter what we eat, how much we exercise, how resilient our genes are, how skinny or young or wise we are, none of it will matter unless we are breathing correctly. And that is what research has told us. So the missing pillar in health is breath. And it all starts from breath. Thank you very much.
Thank you, sir. We'll now have a minute for any questions. Thank you, sir. That was a wonderful session. I'd like to request Dr. Preeti Mary, Consultant ENT Surgeon at the Medical Trust Hospital in Ernakulam, to kindly felicitate the chairperson.